So thank you for coming. My name is Chettipally. We've been doing these physician innovation meetings through SOAP for the last 5 years. And this is the first time we are doing a big global meeting. Well, we didn't realize that so many people will show up. Otherwise, we would have taken a bigger hall. But it's nice to know that there is a need and also that there is this thirst for innovation. My background, I'm an emergency physician. I've been with Kaiser Permanente for about 26 years. And I got out of Kaiser last year, and I'm doing this full-time, consulting, innovation consulting, and also helping get the word out, right? So physicians have always been in this spot where they take the brunt of whatever is happening in the industry. Whether it is coming from the hospitals, whether it's coming from the insurance companies, whether it's coming from pharma, but they've been dealing with this. I don't want to call it abuse, but it almost sounds like that. So this is one way where we can take the science of innovation, the science of medicine, and you conquer those other things that put you down, all right? So innovation is a great way. The way I got into innovation is about 10 years ago, I started a group called Crest Network at my place of work. It's working? All right, good. And two of us, we said, there's so much data in our system. How can we leverage it, or how can we make it useful for the physician? And that's how we started. I have a little bit of tech background. I did a startup in the technology world, so I thought, okay, I'll be the tech guy and you be the grant person. So he started applying for grants, and slowly that group grew to, right now I think there are about 14 physician scientists working on different projects, and that's where I got my taste for how much we can leverage technology for the betterment of physicians and also patients. So that's where I started, and the SOAP group is from the Bay Area. If you haven't gone to one of those, you should come. We meet once a month. How are we doing here? I can keep telling jokes. So one of the things what I figured was, we have EHR everywhere, right? And now EHR is becoming a problem because there's so much work, extra work that we need to do. Now imagine if a physician wants something from the EHR. It's like pulling teeth, right? If you want some kind of report or any kind of tools that are useful to us, it's impossible. In a way, I think we are pampering the EHRs. We are pampering the technology. We're not making it work for us. We are working harder to keep the technology going, but the technology is not working harder for us. So that's my thesis in general, and we need to innovate. Nobody else is going to do it for us. So we need to come up with ideas. We need to come up with projects, products, entrepreneurship, everything, so that it'll help the physicians. Okay, I'll get back into my box. So that's my disclaimer. All right, so if you look at the big picture in healthcare, we are a very small part of it. All these other things that overpower what we can do are huge, monumental. But we are the core of clinical science, right? Nobody can deny us that. So what I would say is that we need to get back to our basics, which is the clinical science. If we can master that through technology, generate new knowledge, generate new ways of taking care of patients, generate that innovation, we will again take the lead in this change that is happening. So In your health system, you might feel like this, it's a dragon you're trying to control. You want to, make it do things that for you, but, that's how I felt. Now, why is all this change happening? Why is all this, am I supposed to get out? Okay. Thanks. Why is all this change happening all of a sudden? So the big changes, the big things that are happening is, population is getting older, so there are going to be more and more costs. If you're younger, it's much cheaper to take care of you. As you get older, it gets more expensive. We spend a lot of money. Everybody knows this. The blue line is the U.S. Is the economy in trillions. And then you have China, Japan, Germany. And that's where healthcare is. That's how much we spend, almost as much as the whole country of Germany. And that's a big chunk. We have science, people are doing research. There are a lot of studies that are being published. We're not able to use all of them, but there's a lot of data there. The technology, and of course, it's leading to burnout, as you've heard the previous speakers talk about. But the technology has been improving. It's gaining so fast. All these trillion-dollar companies, they weren't there 20 years ago. Or, you see these things coming, and the change is so rapid. I'm sure it will eventually hit healthcare. So what I want each one of you to remember or to learn, take-home point. One take-home point is, if you're not there at the leading edge, you will be run over. So that's how you need to learn skills. That's how you need to learn, where your clinical skills and where your business or technology skills will be useful. So how do you change a big healthcare system? How do you make it learn new things? One of the ways we did it is through we built a platform, and the platform hooks up with the EHR. You get data from the EHR, you get data from the physicians while they're seeing the patient. You get data from the researchers because they can decide, okay, this is the right way to do it. And then you could also get data from the patient. And you put it all together, you analyze it, and then you deliver a clinical decision support to the physician while they're seeing the patient at the point of care. That's how you propagate the science really fast and really wide. And that's what we did. So what we did was we took, just a simple problem, like for example, since I'm an emergency physician, we said, okay, how many people come in with chest pain? Well, we see 1 million patients in our emergency departments in 21 hospitals in the last place I worked. Out of 1 million patients, 100,000 of them come every year with chest pain. Well, let's see, how can we fine-tune this care for 100,000 patients? It was not easy, but once we set up this platform, once we trained the physicians on how to use it, it takes 30 seconds to use it. What we did was we took these 100,000 patients, you analyze them, and tell the physician, where does your patient stand at this point, looking at these 100,000 patients. So that'll give them a risk score. What are the chances of this person having a heart attack in the next 7 days? Using that answer, physicians, they're very smart. They understand the risks, they understand the science, and then they did the right thing. So we took 10 medical centers, put them as intervention sites, 11 medical centers as controls, and then ran a clinical trial. We need to, again, as I keep telling people who are using technology, you got to do those clinical trials to prove that it works. And it did work. It saved time. The length of stay decreased. The admissions decreased. The observations decreased. The post-discharge testing decreased. So overall, and nobody had a bad outcome. Overall, it was a great system. And you can replicate that with any disease entity. So first you need to know what has happened, right? These 100,000 patients we studied. What has happened in the past? What will happen? It's easy. Once you know how it went, you know how it's going to go, right? And then you can tell the physician, this patient does not need any more testing, or this patient does not need admission, or this patient is sick. Although he doesn't look sick to you at this point, but looking at the data, we can tell, oh, this patient is going to crash in the next 1 month or so. And then they do the right thing. So one of the ways you can study this is, you take a tool from the literature, you apply that and look at the outcomes. And you can do this as a retrospective study. You can also build your models de novo, which means that you can actually design a model and then do it as a clinical trial and then compare the two. So hopefully your model will get better and better with time, right? You take these outcomes and then put it back into the system. And so with one touch of a button, I was able to control the practice of 700 physicians throughout the region, 700 emergency physicians in 21 hospitals. So imagine that, the power of how technology can change the outcomes for the better. So what are the factors associated with this? Well, it has to be scientifically sound. So you cannot just develop a technology and throw it at the physician and say, okay, use this. They're not going to use it. It's going to be trashed. So first you make sure that you build the science, right? You have to understand what is happening right now. You have to study what the literature says. And you have to make sure that it is appropriate. The physician thinks it is appropriate to use it. And it should decrease the effort and time. If it's going to add more work, they're not going to use it. Okay? So make it so simple, so easy that this is much easier than what otherwise they would have done. You have to build in the incentives. Will I lose money if I use your tool? Right? The way we built incentives is each time they're registered, they get a gift card. So you can imagine, physicians love gift cards, especially if it is coffee gift cards. It's just a tip here, if you're thinking about it. And it doesn't have to be a big amount. And it has to expedite patient care, obviously, right? If it's going to slow down the patient care, if it is going to, make it more complicated for the patient, no, it's not going to work. So these are the factors that we found that it works. So if you look at the current system, now academia, they're doing studies, they're doing work, research, because they want to publish, right? That's the goal. So one of the reasons why a lot of research gets published is that, which is not useful for actual patient care, right? Sometimes you think, what are these guys thinking? What are they saying? Why are they even doing the study, right? But the main goal for academia is to publish. Now, associations, whether it is, your college of cardiology or college, they are looking at providers. Okay, what do the providers want? So they are actually focusing on the providers. EHRs, they don't care because as long as they're able to sell it, they're happy. They don't care how good it works or how bad. And the providers are looking at payers. Okay, what will get me paid? If I see 10 more patients, will I get, $100 more? That's what they're looking at. And so everybody's incentives are all over the place. We're not looking at patient outcomes at all. But one thing that is going to change, or is changing already, is patient outcomes will become the measure of how well you're taking care of the patients. How well the drug is working, or how well the device is working, how well the procedure is working. That's going to be the ultimate answer. And I would advise all physicians who are in practice to focus on that. How do you get there? Because the longer you wait, the harder it's going to be when the switch happens. And the switch is going to happen. I'm talking about value-based care, outcomes-based care. Okay, computers are useless. They can only give you answers. So it's up to us to ask the right questions. The tech guy next door, he can't answer the question. He can't ask the right question, right? They may think that, oh, having an EKG on your wristwatch is great. That's what they think, right? But a clinician will say, doesn't matter. A researcher will say, well, what is the level of AFib in the population that you're giving? Yeah, it's 1%. Who cares, right? Okay, what are the outcomes? Well, are you saving any strokes in the end? How many of them are going on anticoagulants? So those questions, they have no idea. They're just making some stuff up. And they're putting a lot of money in there. So it is up to us to figure out what the questions are going to be. I hope you'll start thinking about those questions. The answers are all there. We just have to figure out the questions. Okay, that ends my talk. Did I save you some time?
Oh yeah, thank you so much.